Hello everybody, today I am going to present a case of postaural epidermoid cyst in a 12-year-old boy. As you can see, he presented with a painless swelling behind the right pinna since 6 to 7 years, slowly increasing in size, and the FNAC showed epidermoid inclusion cyst. So I decided to excise the cyst under local anesthesia. So after local infiltration over the cyst, I am making an incision with a 15 number blade. The incision here has to be made carefully so as not to rupture the cyst wall, which is immediately subcutaneous. So one must be very careful when making the incision. That is, it should only involve the dermis and the epidermis, and the subcutaneous tissue should be dissected very carefully. Sometimes the cyst wall is often thinned out due to long-standing pressure, and one may inadvertently rupture the cyst wall and cause the cheesy debris to come out. In this case, the dissection becomes difficult, and sometimes the planes of dissection can be missed, and there will be chance of recurrence of the cyst. So one must try not to injure the cyst wall while dissecting. So dissection has to be a little careful. Otherwise, that is the main challenge of this surgery. Otherwise, it is a commonly performed surgery and very easy to do. There are no major structures present. It is usually located subcutaneously. So epidermoid cysts are present usually since birth, but they sometimes manifest a few years after birth, and they sometimes slowly progress in size, and they are painless unless they get infected. The etiopathogenesis is entrapment of the epidermal cells, the squamous epidermal cells beneath the skin, and because of the entrapment of these cells at birth, there will be a breakdown of the cells and formation of keratin debris, which presents as a cheesy liquid filling the cyst, and it is brownish in color, yellowish to brownish in color. Dermoid cysts may present with even the appendages of the skin, that is the hair and the hair follicle sometimes, and also a bits of the sweat glands and sebaceous glands. These may be present within, but an epidermoid cyst mainly contains keratin debris. So the only modality of treatment is complete excision. One must remove the cyst in toto, otherwise it can recur if any part of the cyst wall is left behind. So one must be careful while dissecting the cyst all around. Usually, since these cysts are present at birth, they will cause pressure of the underlying tissue. So whatever apparently appears the size of the cyst, while actually excising, one will see that the cyst goes deep inside. If it is adjacent to the bone, then there will be, because of the pressure of the bone since birth, there will be a depression of the bone, and here in this case you can see that it is very close to the pinna cartilage, the conchal cartilage. It is going up to the cartilage, up to the perichondrium, that is. So one must dissect very carefully right up to the depth of the cyst. So the medial aspect of the cyst buries much deeper than one actually assumes when looking at the cyst from outside. Usually it will be double the size. So here you can see that using the Colorado needle, I am carefully dissecting the connective tissue fibers outside the cyst wall. One must leave a bit of the cyst wall and not make it very thin. So a layer of tissue, that is a capsule of the cyst, should be preserved while dissecting it. Any inadvertent rupture can cause cheesy debris coming out of the cyst wall. In such a case, the cyst collapses and the dissection becomes very difficult, and one may actually leave behind some cyst wall, which leads to recurrence. Here you can see that the cyst wall has caused an indentation of the pinna cartilage, the conchal cartilage, and it is going very close to it. One must not injure the conchal cartilage while removing the cyst. That's the last bit of the cyst which is being removed with the monopolar needle. and that's the cyst excised in entirety. At places it has been thinned out, as you can see. So that's the epidermoid cyst, and one must look at the surgical bed to look for any hemostasis. Small bleeders have to be cauterized. And now I'm closing the wound in a single layer, taking deep bites through skin and subcutaneous using 3O Vicryl. So I will put a pressure dressing to avoid any dead space. That is, I do a mastoid dressing here, and I remove the dressing after 1 week so that the wound heals well and the dead space is completely obliterated, and there is avoidance of any seroma or hematoma postoperatively. And I have put the child on 1 week course of antibiotics and analgesics and call after review. So this is suturing which is complete. This is 2 weeks after the surgery where I have done the suture removal. The wound is healed well. Thank you for watching.